Hello, 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 ladies and gentlemen. Hello. We are talking about hepatic disorders today, hepatic and biliary disorders today. So, the class outcomes for hepatic disorders, we are going to identify the different types of hepatitis and their causes, discuss the prevention procedures of all types of hepatitis, contrast the 5 most common forms of viral hepatitis, including similarities and differences in their acute and chronic medical and nursing management. However, ladies and gentlemen, I am only going to address the 3 most common in this class, and that will be hepatitis A, hepatitis B, and then hepatitis C. So although for the class outcomes there are 5 right now, I am only addressing 3. And again, that is going to be hepatitis A, hepatitis B, and hepatitis C. Because we are nurses, we are going to formulate a nursing plan of care for a patient with acute viral hepatitis. We will apply a knowledge of the normal pathophysiology of the liver and its primary functions to the needs of a client with liver disease. We will discuss the diagnostic tools that are used to diagnose liver dysfunction in preparation for client education, because whenever testing is going to take place, whenever your patient is going to go for a procedure, or when lab is coming in to obtain a lab study, the patient should know what the test is for. Contrast the pathophysiology, clinical manifestations, medical and nursing management of varices, portal hypertension, cirrhosis, and hepatic encephalopathy. We will talk about judging the appropriateness and safety of administering the more common medications that are used in treating alterations in hepatic and biliary function. And again, because we are nurses, we will formulate a nursing plan of care for a client that is diagnosed with chronic liver disease. So, the liver is located under the diaphragm in the right upper quadrant of the abdominal cavity, and it will receive approximately 25% of the cardiac output via the hepatic portal vein and hepatic artery. The liver will serve several functions, including blood storage, blood filtration, production of bile, synthesis of the clotting factors such as prothrombin and factors 2, 7, 9, and 10, removal of clotting factors to prevent clotting, and metabolism of carbohydrates, fats, and protein. So the liver also serves to detoxify the blood, and it is a storage area for vitamins A, D, E, K, and iron. Several conditions such as hepatitis. Hepatitis is an inflammation of the liver. And then cirrhosis. Cirrhosis is a chronic liver disease that is characterized by inflammation and irreversible scarring. Liver trauma and liver cancer will all impair the ability of the liver to perform its routine functions. So first we are going to talk about hepatitis. So, ladies and gentlemen, please listen up, and then listen up one more time. The incidence and prevalence of hepatitis is worldwide, and the risk for development is associated with individual behavior and our exposure. There are several viruses that will cause hepatitis, and transmission will either be through fecal oral contamination or directly through blood and body fluid exposures. Some other risk factors will include alcohol use, exposure to some prescription and over-the-counter medications, and toxins, often referred to as toxic hepatitis. In autoimmune hepatitis, an immune system response will cause inflammation of the liver, which can be classified as type 1 or type 2. 25% of adults with chronic hepatitis will develop cirrhosis or liver cancer because of chronic infection with the virus. So the introduction of vaccines for hepatitis A and hepatitis B have greatly decreased the incidence of these types of viral hepatitis. So the pathophysiology of hepatitis. Hepatitis is inflammation of liver cells, most commonly caused by a virus that impairs its ability to function normally. This inflammation will limit the ability of the liver to detoxify substances, limits the production of proteins and clotting factors, and alters the ability to store vitamins, fats, and sugars. Modes of transmission of viral hepatitis include contact with blood, blood products, semen, saliva, and the mucous membranes, direct contact with infected fluids or objects, or through the fecal oral route with contaminated water or food such as shellfish. Patients may experience a mild or severe illness that can be acute or chronic. The most common hepatitis viruses are hepatitis A, B, and C. Hepatitis B is unique in that it is caused by a DNA virus, while the other types are RNA viruses. Some clinical manifestations of hepatitis. Clinical manifestations include abdominal pain, irritability, pruritus. Pruritus is a fancy name for itching of the skin, malaise, fever, nausea, vomiting, jaundice. Jaundice is the yellowish skin color, and laboratory abnormalities such as an elevated liver enzyme, such as an AST or an ALT, elevated bilirubin, both the total and direct, an elevated serum ammonia, and then a decreased albumin level. Patients can also exhibit jaundice or yellowing of the skin or sclera. Symptoms can be mild or severe and vary from patient to patient according to the degree of liver involvement. Patients may present with common flu like symptoms. And then there is something called fulminant viral hepatitis. This is a severe, rapidly progressive, life threatening form of acute liver failure that will include neurological decline, such as encephalopathy, insomnia, somnolence, and impaired mentation. It can also include gastrointestinal bleeding, coagulation disorders, thrombocytopenia. Thrombocytopenia is a low platelet count. It can include a fever, oliguria. Oliguria is a decreased urine output. It can include edema and ascites. Ascites is the accumulation of fluid in the peritoneal cavity that is secondary to low serum albumin levels. So, hepatic encephalopathy will present with impaired mentation, altered levels of consciousness and confusion, somnolence, and insomnia due to the accumulation of toxins in the bloodstream that are normally cleared by a healthy liver. In severe hepatic failure, the liver is unable to metabolize waste secondary to severe inflammation, and because the hepatocytes are just simply liver cells, they are not functioning properly. Due to scarring of the liver, blood will bypass the liver and then it is not detoxified. So the toxins will tend to accumulate in the bloodstream. So, ladies and gentlemen, please listen up, and then listen up one more time. We are talking about types of hepatitis, and I'm going to start with viral hepatitis. Hepatitis A is the most common type of hepatitis, and it is primarily spread through the oral route from food, water, or shellfish that has been infected with the virus. It can also be spread through close contact with infected persons, such as in households and daycare centers, and an increased incidence in the presence of unsanitary conditions. The hepatitis A virus can be found on surfaces, but It is destroyed by cooking food thoroughly. So, hepatitis A is an acute infection lasting as long as 8 weeks, and it will have several phases. The first phase can last for about a week, and it will present with an abrupt onset of fever with anorexia. And, ladies and gentlemen, here when I am talking about anorexia, I am talking about loss of appetite. They can also present with nausea, vomiting, malaise, abdominal pain, myalgia, diarrhea, urticaria, are pale red raised bumps on the skin. They may have a cough and something that we call hepatosplenomegaly, and that is an enlarged liver and or spleen. So, clinical manifestations of later phases include clay-colored stools and a rise in serum bilirubin levels, and jaundice may occur within 4 to 30 days after the onset of the infection. Clinical manifestations in patients with hepatitis A are usually mild, and some patients are completely asymptomatic. The most definitive diagnosis of hepatitis A is through a blood test for the presence of anti-hepatitis A immunoglobulin, M, which can be elevated for as long as 6 months. So, ladies and gentlemen, listen up, and then listen up one more time. Hepatitis B virus is spread by blood and body fluids or secretions such as semen. The virus can be spread through mucous membranes, contact with infected fluids, during childbirth, or through skin puncture with contaminated needles or other instruments. So, when I'm talking about this, think about body piercings, think about tattooing. Patients infected with hepatitis B can have acute or chronic infections and are considered infectious as long as antigens are present in the bloodstream. There is a vaccine for hepatitis B that is required for all healthcare personnel. And ladies and gentlemen, you know this because you also have to receive the hepatitis B vaccine. Hepatitis A and hepatitis B vaccines may be required for entry into daycare, elementary schools, and middle school. Risk factors for hepatitis B include sexual contact with infected persons, multiple sex partners, injection drug use, hemodialysis, blood transfusions, and occupational exposure. Acute hepatitis B occurs after an incubation period of 4 to 10 weeks, and chronic hepatitis B is diagnosed by detectable serum HBV DNA levels and persistent elevation of ALT and AST levels. So, high risk patients with hepatitis B should be screened every 6 to 12 months for something that we call HCC, and this is hepatocellular carcinoma. Screening will include an ultrasound and a serum alpha fetoprotein. This is a protein that is produced by the liver. So we're going to do this level and we are going to look at it as a marker for liver cancer. Because patients with chronic hepatitis B infection can still spread the virus to others, it is important to educate these patients about screening and vaccination of close family members and sexual partners to prevent the spread of the infection. So, ladies and gentlemen, listen up, and then again, listen up one more time. Hepatitis C virus is spread through blood or body fluids and from mother to child during childbirth. A significant number of cases of hepatitis C occur from the sharing of contaminated needles by IV drug users and unintended needle sticks in the healthcare environment, which should be no longer happening because in many facilities, in most facilities actually, we now use a needleless system. Other risk settings will include tattoo and body piercing establishments because of the chance of contact with blood. So, infection with hepatitis C can be acute or chronic. Medical management of hepatitis C is available with established cure rates. However, treatment can be very costly. Treatment will include antiviral medications such as Golcovir, Viread, and Epivir that will reduce viral replication. Now, of course, there are many. If you watch TV, if you see television commercials, there are many, many medications out there now, many more than I could possibly name for hepatitis C that will actually stop the progression of the disease and bring the levels of detection down so low that they are actually considered cured. So there is currently no vaccine for hepatitis C. And again, there is ongoing research and then treatments may cure most patients. Hepatitis C is the most common indication for liver transplantation. Non-viral forms of hepatitis, ladies and gentlemen. Non-viral forms of hepatitis are caused by ingested, inhaled, or injected toxins or medications. Patients with non-viral forms of hepatitis have clinical presentations that are similar to those of viral hepatitis, such as anorexia, nausea and vomiting, jaundice, and hepatomegaly. Diagnosis includes a detailed history and physical exam and a history of exposure to any potential toxins. It is if it is determined that the patient has been exposed to a liver toxin and the toxin is removed, then the patient's recovery can be very rapid. If there is a prolonged period between exposure to the toxin and the development of the clinical manifestations, recovery will be prolonged or not at all if the toxin is not identified. So now let's talk about acute versus chronic hepatitis. Hepatitis can be acute or chronic, and it is differentiated by the length of time a patient is infected with the virus. So, an acute hepatitis infection may last less than 6 months, recovering from all of their clinical manifestations. Chronic hepatitis is an infection that will last longer than 6 months and can span the patient's lifetime. So 6 months is the marker there. Having the virus for a prolonged period will increase the patient's chance of developing complications such as cirrhosis, liver failure, or liver cancer. So patients who contract hepatitis B and hepatitis C can develop chronic hepatitis that can lead to progressive liver damage and cause primary cancers. Management of clinical manifestations and routine monitoring of the disease and medical care can help prevent the progression to liver cancer. So, acute versus chronic hepatitis, continuing. In patients with hepatitis C, the risk for liver cancer is decreased for patients on antiviral therapy because this therapy will prevent the virus from reproducing, and this is going to slow the progression of the liver damage. The treatment course and antiviral medication choices are based on the age of the patient, the severity of the illness, adverse reactions, their medication tolerance, their viral load, ALT levels, and the patient's compliance with the medication regimen. So, how is this diagnosis? How is this diagnosed? Laboratory and diagnostic testing will include assessments that determine the extent of liver damage, and this will guide diagnosis. Diagnostic test results and a thorough physical exam are important in the determination of the cause of the patient's clinical manifestations. So, doctor will monitor the AST and ALT levels along with the clinical presentation of the patient, and this will provide information about whether these elevations are associated with the liver alone or with another major organ. Often, abnormalities in a liver panel may not be associated specifically with the liver. An AST level that is extremely high indicates acute hepatitis, most often caused by a virus. May also be associated with exposure to medications or other hepatotoxins. Liver enzymes are measured serially over time to monitor recovery or worsening of the disease, and 2 laboratory values that indicate abnormalities, of bile flow of gamma glutamyl transferase, otherwise known as GGT, and alkaline phosphatase. So, doctor is also going to monitor these 2 lab studies along with the AST level and the ALT level of the liver enzymes. GGT is a protein that is found in the liver and bile ducts. High levels of this enzyme can indicate inflammation, injury, or blockage of the bile duct, and we call this cholestasis. Alkaline phosphatase is an enzyme found in the bone, intestines, liver, and bile ducts. When elevated, this will indicate a blockage of bile flow that can be caused by gallstones or scarring in the biliary tree. Serum albumin will measure the amount of protein that is made in the liver, and a low serum albumin may be an indicator of liver damage and malnutrition. Please, ladies and gentlemen, please continue to connect a low serum albumin level with liver damage and malnutrition. Please remember. Please take note. Medications for hepatitis. Approved therapeutic medications for use include oral antiviral agents for viral suppression. There are too many to name. So there's just too many to name. And that is simply what an antiviral will do, and that is going to stop the replication of the virus. Use of immunoglobulin is recommended if exposure to the source of hepatitis A is less than 2 weeks. The hepatitis A vaccine is also recommended, and pegylated interferon injections will also work toward viral suppression. Vaccination for hepatitis B is recommended for all children as well as adults in high-risk categories. Patients undergoing medical treatment are followed serially over time to monitor liver function tests, and we call these LFTs, and their treatment response. Ladies and gentlemen, please listen up. Listen up now on page 1460, table 59.4. Vaccines for hepatitis. Ladies and gentlemen, you will know this table. So, diet and activities for hepatitis. Diet recommendations are similar to a healthy diet. So, we want them low in fat and high in fruits, vegetables, and whole grains. Adequate fluid intake is also important to ensure hydration. If the liver is damaged, it is unable to store large amounts of glycogen for energy, and eating small, frequent meals will help the liver restore their glycogen reserves. Patients should avoid alcohol and any medication that is toxic to the liver, such as acetaminophen, which we also know as Tylenol. Vitamin supplements A, D, E, and K can be beneficial. There is no recommended exercise program and no specific exercise is restricted. Activities such as walking, resistance training, and low impact aerobics will help maintain strength and minimize fatigue. And it is important for patients to maintain a good balance of proper rest and exercise. So now let's talk about surgical management. And surgical management here involves liver transplantation. Hepatitis C related cirrhosis is the most common reason for liver transplantations. Currently, liver transplantation occurs primarily from a cadaver donor through a procedure known as orthoptic liver transplant. The native diseased liver is then removed, and a cadaver donor liver is transplanted into its place. A living donor liver transplant can occur. A lobe of the liver, usually the right lobe, is removed from a donor and then transplanted to the recipient after the deceased liver has been removed. Patients undergoing these procedures require intense patient education, support, and long-term medical management. The major complications after liver transplantation are organ rejection and infection. So organ rejection will present between days 4 and 10 postoperatively and is characterized by fever, right upper quadrant pain, tachycardia, their change in bile, and jaundice. So, to reduce the risk of rejection after liver transplantation, the patient will be placed on immunosuppressant medications such as cyclosporine and something called tacrolimus. So, now let's get to the care plan. Now, let's get to the care plan for this patient. So, assessment and analysis. Many of the clinical manifestations that are observed in patients with hepatitis are directly associated with the inability of the liver to perform its normal functions because it is inflamed. So, some common findings will include an elevated temperature that is associated with this inflammation, elevated LFTs, those liver function tests, jaundice, fatigue, decreased appetite. Some nursing diagnoses on the problem list for patients with hepatitis: activity intolerance associated with fatigue, fever, and flu like symptoms, acute pain that is associated with edema of the liver, altered nutrition, less than body requirements, associated with decreased liver metabolic function, secondary to loss of appetite, nausea, and vomiting. Altered thought processes associated with elevated serum ammonia levels, secondary to liver dysfunction, and excuse me, and then knowledge deficit associated with the disease process. So, let's talk about some nursing interventions for this hepatitis patient. We are going to assess, because we are nurses and that's what we do, we are going to assess vital signs. Elevation in temperature and pulse will be associated with the infectious process. We are going to make note of those serum liver enzymes. Elevated levels of liver enzymes indicate that liver injury is present and liver enzymes have entered the bloodstream. Serum bilirubin, total bilirubin, and direct or conjugated bilirubin levels are elevated because of inflammation and obstruction of the liver by hepatitis. We are going to assess the color of the skin and the sclera. Yellow pigmentation of the eyes and skin occurs because of increased levels of bilirubin in the blood. We are going to note their nutritional intake. Loss of appetite occurs because of abdominal fullness or the lack of desire to eat foods the patient previously enjoyed as a result of indigestion. And then we are going to monitor their weight. Monitoring nutritional intake and evaluating weight loss associated with decreased nutritional intake. Anorexia may develop secondary to abdominal distension and obstruction. And again, ladies and gentlemen, when I am talking about this, I am talking about loss of appetite. So we are going to monitor intake and output. Fluid volume status, either overload or depletion, can occur. Fluid overload is often associated with ascites that can develop secondary to damage to the liver by the inflammatory and infectious process that is seen with hepatitis. And if our patient has gone to surgery and if they have received a liver transplant, we are going to monitor for signs of organ rejection in the patient after the liver transplantation. In patients who undergo transplantation, organ rejection may occur within the first 10 days after the procedure and may include right upper quadrant pain, changes in bile drainage, fever, tachycardia, and jaundice. So, some nursing actions for hepatitis. We are going to administer medications as they are ordered. We will provide small, frequent meals and supplements if they are needed. Because of decreased appetite and feelings of fullness, small, frequent meals and nutritional supplements are encouraged to promote adequate nutrition. We will administer antiemetics. However, we will use caution. Some antiemetics, such as phenothiazine, are metabolized by the liver and they should not be used. So we need to be careful. We will promote balance between physical activity and rest. Rest will decrease metabolic demands on the liver, and we will encourage rest periods between activities. Energy conservation for this patient is very, very important. We want this liver to heal. So, teaching for hepatitis, some patient education for hepatitis, we are going to do nutritional teaching. The importance of balanced nutrition to promote energy and small, frequent meals to increase nutritional intake while minimizing the negative effects of eating. It is important to stress calorie intake and proteins in moderate doses because the liver processes protein. We will limit fat intake because of the liver not being able to make enough bile to process the fats. Hydration is important to manage symptoms including dizziness, fatigue, skin and mucous membrane dryness, and side effects of any medications. Good hand hygiene before and after meals and after the use of the bathroom to decrease transmission from the fecal oral route. Avoid behaviors such as needle sharing, unprotected sex that will contribute to transmission. Mode of transmission of the diagnosed form of hepatitis must be included in the discharge teaching. The importance of vaccinations to prevent hepatitis A and hepatitis B. It is recommended for healthcare workers, food handlers, childcare workers, and travelers. It is a series of 2 injections. So there will be the initial injection and then a booster 6 to 12 months later. And then the hepatitis B vaccine is recommended for everyone. And then how do I know? How do I know that I've done a good job taking care of this patient with hepatitis? Hepatitis will be manageable when patients have a clear understanding of the disease and are compliant with interventions and therapies. Expected outcomes will include stable vital signs, a stable weight, and a comprehensive understanding of the risk factors, transmission, and treatment. Additional outcomes will include a decrease in liver function test values. Lifestyle activities that will contribute to liver disease should be altered or eliminated to slow the progression of the disease. Knowledge of diet, nutritional intake, activity tolerance, and compliance with medical interventions are necessary. Patients require serial follow-up and monitoring of symptoms and should take a proactive role in their self-care. So, ladies and gentlemen, we are going to move on to cirrhosis of the liver. So, how does this happen? The epidemiology of cirrhosis. So, cirrhosis is the end result of most chronic liver diseases. It is the third most common cause of death in people ages 45 to 65 years of age. Most patients with cirrhosis, however, will die in their 50s and 60s because the liver has had many years of exposure to viruses, toxins, or other medical conditions. Risk factors that predispose a patient to develop cirrhosis will include chronic infection with hepatitis A, B, or C, followed by chronic alcohol use disorder, biliary disease, accumulation of fat in the liver, and some autoimmune diseases. So, improving health habits and refraining from those risky behaviors, such as needle sharing and unprotected sex, refraining from consumption of alcohol, and receiving vaccination for hepatitis, are steps that can be taken to prevent cirrhosis. Alcohol-induced cirrhosis, also known as Laney cirrhosis, is now the second most common form of cirrhosis and results from chronic alcohol use disorder and consumption. Biliary cirrhosis is defined by scarring of the liver tissue around the bile ducts and lobes of the liver because of chronic biliary obstruction and infection or cholangitis. Cholangitis is simply inflammation of the common bile duct. Genetic causes of cirrhosis will include something called Wilson's disease and hemochromatosis, and we know this to be iron overload. In Wilson's disease, there is an abnormality of a protein that will cause excessive accumulation of copper in the liver, leading to chronic inflammation. So, pathophysiology of cirrhosis. Cirrhosis of the liver is a chronic disease that will cause cell destruction and fibrosis or scarring of hepatic tissues. In a normal, healthy liver, blood will flow through the portal vein, in contrast to a cirrhotic liver where the blood flow is dependent on the hepatic artery. Alteration of blood flow to the liver results in portal hypertension. This is an increase in the pressure in the veins that will carry blood through the liver, and shunting of blood around the liver, therefore bypassing the liver. And again, these toxins are going to accumulate in the bloodstream. Shunting of blood around the liver causes increased pressure in the surrounding vessels, resulting in what we call esophageal varices and gastric varices. And these are abnormally dilated and weak veins. And this can result in what we call an upper GI bleed. Other pathophysiological changes that develop secondary to altered blood flow will include ascites, coagulopathy, and hepatic encephalopathy. Patients with significant liver disease are thrombocytopenic and have a prolonged PT. And we know that thrombocytopenia is a low platelet count. Some patients may exhibit significant bleeding, leading to what we call disseminated intravascular coagulation, otherwise known as DIC. In DIC, small blood clots will form inside the blood vessels, disrupting blood flow, leading to the organs, and disrupting normal coagulation, leading to excessive bleeding from the GI tract, the pulmonary system, a wound, and any skin puncture, such as an IV site. Hepatic encephalopathy is characterized by numerous disturbances in the central nervous system, including changes in motor function to changes in levels of consciousness, ranging from restlessness and confusion to seizures and coma. Patients with hepatic encephalopathy can be staged based on the severity of their clinical presentation. Cirrhosis is irreversible once it develops, and treatment will focus on preventing progression and complications. Some clinical manifestations of cirrhosis. Based on the degree of liver involvement, the clinical manifestations may vary and get progressively more pronounced as the liver dysfunction worsens. So, clinical presentations include shortness of breath, jaundice, an increase in abdominal girth, abdominal pain and bloating, and an enlarged spleen. Other clinical manifestations include elevated liver enzymes, an increased risk of bleeding, thrombocytopenia, again, that is a low platelet count, a prolonged PT, prothrombin time, hemorrhoids, elevated serum ammonia levels, a change in the level of consciousness. Additional clinical manifestations include changes in motor function, hyponatremia. Hyponatremia is a low serum sodium level. And then something called asterixis, and this is a flapping tremor of the hand when the hand is extended. So, how is this diagnosed? How is cirrhosis diagnosed? Laboratory and diagnostic testing will include assessments that will determine the extent of liver damage to guide diagnosis. Diagnostic ultrasound and computed tomography, otherwise known as CT scans, are non-invasive tests to determine abnormalities in the liver. An EGD is a minimally invasive procedure that will use an endoscope to visualize the GI tract from the esophagus to the duodenum to evaluate for esophageal varices or bleeding. Percutaneous transhepatic portal angiography is used to visualize the portal venous system and obtain a liver biopsy. Percutaneous transhepatic cholangiography is a radiological test that will use a contrast medium injected into the bile duct of the liver to visualize the biliary tract and identify obstruction that, if identified, can be treated with the insertion of a drain or a stent. And then a liver biopsy is an invasive procedure done to collect a sample of liver tissue to determine the severity of liver disease. Now, ladies and gentlemen, please listen up and take note. On page 1465, there is a safety alert regarding taking care of a patient post-operatively after a liver biopsy. Please, ladies and gentlemen, please take note of that safety alert. And then treatment of cirrhosis. Ascites requires restriction of sodium intake to less than 2 grams per day and administration of diuretics to increase salt and water excretion. So in patients with end-stage liver disease that is secondary to cirrhosis, it is necessary to perform routine and frequent paracentesis for ascites that will require the removal of several liters of fluid to relieve the patient's clinical manifestations of abdominal bloating, pain, and shortness of breath. With the removal of this fluid, the patient may develop hypotension, which is going to require close monitoring, both during the procedure and post. Treatment of portal hypertension requires symptom management and controlling complications of bleeding. Patients may undergo endoscopic procedures such as banding or sclerotherapy, and this is a procedure that is used to shrink the veins. Banding will involve placing bands around the varices to block the bleeding. Sclerotherapy involves the injection of a solution into the bleeding varices to make them shrink to stop the bleeding. Some patients may also be given beta blockers to lower systemic blood pressure. So, ladies and gentlemen, listen up, and then listen up one more time. Patients with uncontrolled esophageal variceal bleeding were treated with a Send-Staken-Blakemore tube, which is inserted into the GI tract through the nose to provide compression and traction in the esophagus and stomach to stop hemorrhage. And this is sometimes called a balloon tamponade. The modality of treatment is rarely used, and emergency providers must be very confident in this modality in order to use it. Complications of balloon tamponade include airway obstruction, esophageal rupture, and then aspiration pneumonia, because this tube can in fact travel. It is only held in place with the balloon, as such as a Foley catheter. So it can move, and so with that risk is the risk for complications. And on page 1465 as well, there is a safety alert for the Send-Staken-Blakemore tube, and you will know that safety alert as well. Please, ladies and gentlemen, please continue to listen up. Management of patients with hepatic encephalopathy will include avoiding protein overload, decreasing bacterial production of ammonia, and correcting fluid and electrolyte imbalances. So, doctor may order lactulose. Lactulose will decrease the production of ammonia and it will promote its excretion in the stool. And this can be given either orally or via a rectal enema. So, surgical management of cirrhosis. In some cases, patients with ascites require surgical intervention that includes the placement of a shunt between the portal venous system and the systemic venous system to reduce portal pressure and fluid accumulation. This type of shunt is known as a transjugular intrahepatic portosystemic shunt, otherwise known as TIPS. Cirrhosis is also an indication for liver transplantation. So, some complications of cirrhosis. In addition to complications associated with ascites, portal hypertension, coagulopathies, and hepatic encephalopathy, patients with cirrhosis are also at risk for hyponatremia, hepatorenal syndrome, and spontaneous bacterial peritonitis. The significant changes in liver function secondary to cirrhosis often result in liver failure. Some patients may develop hepatorenal syndrome, which is characterized by a rapid deterioration of kidney function as a result of altered blood flow to the kidneys. Spontaneous bacterial peritonitis is the development of peritonitis in the abdomen that can occur in patients with chronic cirrhosis, and clinical manifestations will include fever, abdominal pain, encephalopathy, or acute hemodynamic decompensation. So now let's get to the care plan for taking care of this patient. So we are going to assess, because we are nurses, we are going to assess. Many of the clinical manifestations that are observed in patients with cirrhosis are directly associated with the inability of the liver to perform its normal functions. So some common findings will include shortness of breath, a decreased blood pressure, petechiae. Petechiae are small red or purple spots on the skin. We may see bruising or bleeding. Altered mental status, asterixis. More clinical manifestations include elevated liver enzymes, jaundice, dark amber urine, increased abdominal girth and bloating, a decreased serum albumin level, something that we call spider angiomas, palmar erythema, pruritus, and this will be secondary to the accumulation of bile salts. And now, ladies and gentlemen, please listen up and take note. Other clinical manifestations include acid-base disorders, including respiratory alkalosis and metabolic alkalosis. Metabolic alkalosis can occur because of vomiting, fluid loss, diarrhea, and the use of diuretics. Ladies and gentlemen, please take note of this slide. Some nursing diagnosis and a problem list for cirrhosis. Fluid volume excess associated with water and sodium retention, secondary to decreased plasma proteins, otherwise known as albumin. Fluid volume deficit associated with third spacing of peritoneal fluid, otherwise known as ascites. Coagulation abnormalities, and variceal bleeding. Altered nutrition, less than body requirements, associated with altered liver metabolism of nutrients, impaired absorption of fat-soluble vitamins, B vitamins, and then insufficient intake. Impaired skin integrity associated with compromised nutrition, edema, decreased immune status, and accumulation of bile salts. Risk for injury, bleeding associated with coagulopathy, risk for injury, falls secondary to changes in the level of consciousness due to increased serum ammonia levels. So, ladies and gentlemen, nursing interventions for that patient with cirrhosis, we are going to assess. Ladies and gentlemen, please listen up, and then listen up one more time. We are going to assess their respiratory status for shortness of breath. Adventitious breath sounds, decreased breath sounds, and an increased respiration rate may indicate pulmonary fluid overload or the inability to lower the diaphragm because of ascites. We are going to monitor vital signs. Blood pressure may be elevated because of fluid volume excess. Blood pressure may be low because of the fluid shift out of the vascular space, secondary to decreased oncotic pressure and low serum albumin. We are going to monitor peripheral edema secondary to fluid retention. Fluid shift into tissues is associated with retention of sodium and water and decreased albumin. We are going to monitor abdominal girth, increased girth due to accumulation of fluid in the peritoneal cavity. We are going to monitor for bleeding, bleeding gums, ecchymosis, which is bruising, epistaxis, which is a nosebleed, and petechiae, again, those small round spots on the skin as a result of bleeding. These are complications of decreased clotting factors and a vitamin K deficiency. We are going to monitor the skin, the sclera, urine, and stool color. Signs of jaundice, along with dark urine and clay-colored stools, are associated with increased bilirubin levels due to the inability of the liver to secrete bilirubin into the bile ducts or because bile flow is blocked. And we are going to monitor their mental status. Signs of anxiety, behavioral or personality changes, lethargy, and stupor will indicate hepatic encephalopathy secondary to the elevated ammonia level. Ladies and gentlemen, please listen up, and then listen up one more time. For more nursing interventions, we are going to put this patient on intake and output. Fluid status requires vigilant monitoring due to the risk of fluid retention, secondary to ascites, diarrhea, and then potential blood loss. We are going to monitor their weight. Increased weight will indicate fluid retention. And then we are going to monitor the acid-base balance. Elevated serum ammonia levels, hyperventilation, and hypoxemia will contribute to the respiratory alkalosis. Metabolic alkalosis can occur because of vomiting and fluid loss, diarrhea, and the use of diuretics. And we are going to monitor for signs of organ rejection if our patient has gone to the OR and if they have had a liver transplant. In patients who undergo transplantation for cirrhosis, organ rejection may occur within the first 10 days after the procedure and may include right upper quadrant pain, changes in bile drainage, fever, tachycardia, and jaundice. Ladies and gentlemen, please listen up, and then listen up one more time for nursing actions for cirrhosis. We are going to administer diuretics. We are going to administer electrolyte replacements such as potassium. Potassium levels may be low and associated with vomiting and diarrhea, secondary to treatment for elevated ammonia levels, the use of diuretics or low dietary intake of potassium-rich foods. Serum albumin may also be low. We will administer magnesium as needed. This will be decreased as a result of poor nutrition and diarrhea. We will administer phosphate as needed, and we will restrict sodium and fluid intake as ordered. Serum creatinine levels may be elevated. Serum sodium levels may be decreased. We will restrict protein intake. Elevated amounts of protein in the diet can raise ammonia levels and lead to hepatic encephalopathy. The head of the bed will be elevated, and we can also elevate the legs. Administer vitamin K, blood products, and fresh frozen plasma as ordered. And we will promote rest periods between activities so the patient may sit down while they are bathing or dressing. And then teaching for the patient with cirrhosis. We will educate them on the overview of the disease process and dietary restrictions such as protein, sodium, fluid. This will promote knowledge of signs and symptoms of the disease and promote understanding of the importance of following dietary guidelines to prevent progression of the disease process. We will talk about lifestyle changes, no alcohol intake. If needed, we will refer this patient to a support group, and we will educate about medications that are metabolized in the liver, such as acetaminophen, again, that is Tylenol, and then over-the-counter herbs and supplements. We will encourage them to seek routine care for their liver disease, encourage the patient to be proactive in the disease process, and to monitor laboratory values and progression of the disease. Consume adequate calories to minimize weight loss, eating a well-balanced diet with plenty of fruits, vegetables, and whole grains. And we will educate them on the need for care with hygiene, such as a soft toothbrush, being careful when they are flossing, and only electric razors. And then how do I know? How do I know that I've done a good job taking care of this patient that has cirrhosis? Cirrhosis is a manageable disease process when patients have a good understanding of the disease and they are compliant with interventions and therapies. Expected outcomes will include stable vital signs, stable weight, decreased abdominal girth, and the absence of bleeding tendencies. Lifestyle activities that contribute to liver disease need to be altered to eliminate or slow the progression of the disease. And knowledge of diet, nutritional intake, activity tolerance, and compliance with medical interventions are necessary. Patients require routine follow-up and monitoring of symptoms and should take a proactive role in their self-care. If the disease progresses to end-stage symptoms and the patients require hospitalization at the end of life, education and interventions associated with the need for intensive care management, potential transplantation, and or palliative care can be explored. So, moving on to liver cancer. Liver cancer. So, the epidemiology for liver cancer is the third most frequent cause of cancer mortality. Patients may also develop liver cancer secondary to metastasis from another area of the body. The pathophysiology of liver cancer. Risk factors for primary liver cancer include diseases that cause long-term inflammation of the liver, including chronic infection with hepatitis B or C, and a several-year history of heavy alcohol consumption, and this is defined as more than 2 alcoholic drinks a day for several years. Other risk factors include autoimmune disorders, hemochromatosis, and this is a condition that will cause the body to absorb too much iron from food, obesity, and a history of diabetes. Liver cancer is usually fatal within 6 to 12 months of diagnosis, and for some patients, the only cure is a liver transplant. Clinical manifestations of liver cancer. Liver cancer is often asymptomatic until the liver becomes enlarged or the patient demonstrates clinical manifestations of liver dysfunction. Because the tumor impairs normal function of the liver, patients will exhibit abdominal pain, weight loss, anorexia, weakness, fatigue, jaundice, and ascites. The prognosis for patients with primary liver cancer is poor because patients are usually asymptomatic and they are not diagnosed until late in the disease process. If diagnosed early, aggressive surgery can be successful if the tumor is small and slow growing and the liver is otherwise healthy. So, diagnosis of liver cancer. Cross-sectional imaging studies every 6 to 12 months are recommended in patients with cirrhosis, along with assessment of the alpha fetoprotein measurements. AFP blood tests are about 60% accurate in detecting liver cancer. In patients with suspected METs to the liver, ultrasound and contrast CT scans of the liver are useful in identifying tumor growth. Full body scans may also be indicated if the site of the original cancer has not been determined. A liver biopsy may also be performed to determine the type and stage of the cancer. And then treatment of liver cancer. Some patients may undergo a combination of chemotherapy and radiation. Radiation alone is ineffective at slowing tumor growth. Selective internal radiation therapy is considered for patients with liver cancer who cannot be treated surgically and includes delivering radiation directly into the liver via a catheter that is placed in the hepatic artery by an interventional radiology. Systemic chemotherapy may be used for liver cancer, however, it is generally ineffective. Hepatic arterial infusion allows for a more direct, targeted approach to the delivery of chemotherapeutic agents to the liver. Transcatheter arterial chemoembolization is another treatment for liver cancer that involves cannulation by an interventional radiologist of the feeding artery of the tumor. Another treatment for liver cancer is radioembolization, which combines embolization with radiation therapy. Radioactive seeds are implanted into the liver at the tumor site when brachytherapy is used to treat liver cancer. Ablation procedures can also be used with liver tumors, including radiofrequency ablation, which will use energy waves to heat and kill the tumor cells. Liver cancer is also treated with cryotherapy, which uses liquid nitrogen to freeze and kill the tumor cells. Because the hepatitis B vaccine prevents infection of the liver, it can prevent the development of liver cancer. And then surgical management of liver cancer. Surgical options for the treatment of cancer are dependent on the degree of normal liver function and whether it is a primary or secondary cancer. Surgical options for metastatic disease are palliative for symptom relief of pain and distension. In patients with small single liver tumors with normal liver function, a partial hepatectomy may be performed to remove the tumor. Surgical resection is the treatment of choice for those patients who do not have cirrhosis and are not demonstrating significant clinical portal hypertension. Liver transplantation may also be an option in patients with small single primary liver cancer and is the treatment of choice in patients with decompensated liver disease. So, the care plan for a patient with liver cancer. We are nurses and we are going to assess. So, the clinical manifestations in patients with liver cancer are directly associated with the degree of liver dysfunction and will include the following: pain in the right upper quadrant with extension to the back or the shoulder, fluid accumulation in the peritoneal cavity, we call this ascites, anorexia, loss of appetite, weakness, shortness of breath, jaundice of the skin or the sclera, elevated serum liver enzymes, and an elevated bilirubin. Some nursing diagnoses and a problem list for a patient with liver cancer. Pain associated with pressure that is caused by the presence of the tumor. Activity intolerance associated with fatigue and weakness. Risk for ineffective coping associated with changes in the health status and chronic disease process, and ascites. So, some nursing interventions for the patient with liver cancer. Again, we are going to assess, because we are nurses, we are going to assess for shortness of breath. Fluid accumulation in the peritoneal cavity will push up on the diaphragm and cause shortness of breath. Patients can experience hypoxia from intrapulmonary arteriovenous shunting and commonly develop pleural effusions. We are going to assess vital signs, increased respiratory rate and shortness of breath due to increased pressure on the diaphragm, elevated fever, usually associated with infection. We are going to assess for pain. Pain in the upper abdomen on the right side that may extend to the back or the shoulder is associated with the tumor size and location. We are going to assess abdominal swelling and bloating. Ascites or protein-rich fluid accumulation in the peritoneal cavity occurs because of impaired sodium and water retention due to inflammation of the liver, resulting in decreased production of plasma proteins, we call this albumin, and to the presence of the tumor. So we are going to assess for weakness and feelings of extreme tiredness. We are going to assess their weight loss. We are going to monitor their appetite and feelings of fullness, nausea, and vomiting. Gastrointestinal symptoms can be associated with the size of the tumor and the accumulation of ascites, and compression on the stomach, leading to feelings of early satiety and decreased appetite. And we are going to assess their skin color and their eyes. Jaundice will develop, causing yellowish skin color and scleral yellowing secondary to elevated bilirubin levels due to tumor obstructing bile ducts. And we are going to assess their urine color. We are going to assess their abdominal girth measurements daily. Measure and document abdominal girth at the level of the umbilicus. This is standardized to determine fluid accumulation. And we are going to monitor liver enzymes and monitor for trends in laboratory values. All liver enzymes can be elevated because of abnormal functioning of the liver, So some nursing actions for liver cancer. We are going to administer pain medications such as NSAIDs and narcotics via the oral route by IV, subcutaneously, topical patches, and non-narcotic coated lollipops. This will provide symptomatic relief. The use of pain therapy is patient-specific, Some patients respond to non-steroidal anti-inflammatory medications, whereas others require topical patches. Combination of therapies may be indicated depending on the severity of the patient's symptoms. Doctor may do a nerve block. A nerve block may be used and are injected locally directly into the nerves of the abdomen to provide relief of pain. We will administer antibiotics and antipyretics. Antipyretics are used to treat temperature elevations. Apply elastic wraps or bandages or support stockings to lower extremities and elevate the legs. Restrict fluid intake, sodium restriction, and protein restriction. And patient education for that patient with liver cancer. We will provide education on the importance of eating and maintaining an exercise regimen. Importance of limited salt intake is particularly important. Provide patient education about procedures, diagnostic tests, interventions, or treatments. And we will teach the patient about therapies used to control pain and alleviate symptoms with palliative therapy. And then how do I know that I've done a good job taking care of this patient with liver cancer? We will prevent complications of fluid retention and decrease nutritional intake. These are important care outcomes for those patients and for their families. Ladies and gentlemen, as always, thank you for your time and attention. Please reach out with any questions, comments, concerns, or any help that I can offer.